So on to our next specimen. And here it is. So as usual, I'll give you a few seconds to take a look at it.
You want to turn it or?
Yeah, I'm just gonna move it around for you, give you a second to appreciate it from all of its angles.
Okay, I'll watch
And this surface as well. So what do we have here? Is it a retroperitoneal sarcoma? Is it an invasive placenta? Is it a massive goiter? Or is it a sarcoma of the extremity? Excellent, sarcoma of the extremity. Good job, everyone. So the reasons that people might have been familiar, been able to recognize that is some of the tissue that we can see here. So first of all, we have the very classic orientation sutures. So we have our long lateral and our short superior sutures, so that can be helpful. You often see that in sarcomas of the extremity. We can also see some bits of tissue. We can see it looks like some muscle tissue here and some looks like some adipose tissue at one end, and then overlying it looks like we have some nice fascia here. Hopefully you can appreciate that. And then over on this side, I sort of gave you a peek, but not too much. Once again, it looks like we have some fascia, looks like we have some muscle. And looking through it, you can see that it looks like we have quite a large tumor. Okay, so now I've given it away and said that it is a sarcoma. I mean, you might have other things on your differential, but sarcoma would certainly be high given the site. So what exactly is a sarcoma? In the chat, maybe, can someone say how they define a sarcoma? Good, excellent. Anonymous person. So that is a very common definition, is a tumor of mesenchymal origin. Another way that I've heard it defined is because sarcomas can encapsulate so many things, I've heard it defined by what it is not. So it is tumors that are not epithelial, not central nervous system, not hematopoietic, and not lymphoid. So that's another way that they can be described. So it kind of covers a lot of options. Another thing to consider when you're looking at a specimen and trying to figure out maybe what it could be is you want to consider what kind of resection specimen it is. So there's different types, and I think that's a multiple choice question that will come up now. So based on what I've shown you, I'll show you again, what type of resection specimen is it? Is it a marginal resection, a wide resection, a segmental resection, or a radical resection? Okay, so we have a split. It is a dead heat between marginal and wide. We also have a vote for segmental and a vote for radical. Okay, so first of all, I should say that the CAP protocol actually doesn't distinguish between a segmental and a radical. So I'll get to that in just a few seconds. So a marginal resection, so the first type that isn't included here is actually an incisional resection. So that's where you've just taken a section and you've left a lot of the tumor behind. So that's clearly not what this is. Marginal is something that you might do for something benign, where you've just sort of scooped it out and have, you know, if it's encapsulated, have tried to get the whole capsule, but haven't really gotten much in terms of the tissue surrounding it. I can see why some people maybe put marginal. It looks like the margins will be very close in some of these places, but in this case, I think it's just because of the location of the lesion in the extremity. And I haven't told you, this was actually, and there's just, as you can imagine, there's not a lot of space to work with. And the way that you can really tell that it is a wide resection, which is the answer, is if you look at the end bits, you can see, let's see, we can see that where the border of the tumor is, and we can see that they've added quite a bit of tissue at the edge. So in a wide resection, they usually try and add at least a couple centimeters of extra tissue. And the radical resection and the segmental resection sort of go together. So in the segmental resection, I think of that as being they've taken an entire compartment of, let's say, muscle all together at once. So you'd have more tissue with that. And radical is where it might extend beyond into multiple compartments that they've had to remove just because of the nature of the lesion. So that's great, everyone. Thank you for participating. Okay, so the other thing, again, when we're thinking about what it could be, is we want to think about whether, so we've established that it is a wide resection, so that suggests to us that it's probably not something benign, because that's something they'd be more likely to do a marginal resection for. And we also want to think about whether it is superficial or deep, because that, again, will affect our differential diagnosis. So what the next polling question, how do we determine what is superficial versus deep? What delineates superficial from deep soft tissue tumors? Is it the fascia? Is it the dermis, the muscle, or is it a radiologic measurement?
All right, we're ending the poll.
All right, let's see what we have. Oh, and majority rules once again. So soft tissue tumor or sarcoma is considered deep if it's deep to the fascia. So the dermis is not quite deep enough. It is not radiological, and once you're in the muscle, that it would certainly be deep, but that delineation is the fascial layer. Okay, so now we have this deep soft tissue tumor, and it's quite large, and it has a lot of heterogeneity, I hope you can appreciate with this excellent video quality. So as I've previously discussed, sarcomas can arise from a lot of different lineages. So can you guys give me some ideas of what's on your differential in terms of what kind of cell origin this might have come from, this tumor? So just in the chat, any thoughts? Yeah, could be from the fat, so a liposarcoma. Good. Any other ideas? You can look at the side. There's some sort of gray areas at the edges. That tells you anything? Smooth muscle, good. Another good option. You guys know any other kind of cell lineages? There's a bunch more. Good. Skeletal muscle, excellent is good. Fibroblast, one of my favorites. Excellent, good job. There's also some good vessels, peripheral nerves. These are all examples of things that it could be. So in this case, as with many sarcomas, we had a previous biopsy, so that gives us an advantage in that luckily we were able to make the diagnosis on the biopsy, and it was in fact a liposarcoma. Okay, so our next polling question is, and it is, which of the following is not a type of liposarcoma? As per the WHO, is it well diff, dedifferentiated, myxoid, spindle cell, or pleomorphic? And you just throw liposarcoma at the end of that. So we'll see what you all think. Spindle cell, very good. So we have a mix across the board, but the answer is spindle cell. I was being a bit tricky there because there is a spindle cell lipoma, but there is no spindle cell liposarcoma. So all of the other ones are examples of liposarcomas. And in this case, the previous biopsy showed that it was a myxoid liposarcoma, which is a particular kind with very interesting histological features. But it also has a very characteristic fusion, which is actually how the diagnosis was made on this biopsy. So what molecular change is characteristic of a myxoid liposarcoma? Is it MDM2 amplification? Is it a FUS-DDIT3 fusion? Is it a FUS-CREB3L2 fusion? Is it a FUS-FLY1 fusion? Or is it complex cytogenetics that gives it away? Excellent. Okay, so the majority has it. So MDM2 amplification would be seen in a well-differentiated or a dedifferentiated liposarcoma. So that's where you see that. The FUS-DDIT3 is the myxoid liposarcoma, so good job. The FUS-CREB3L2 is the low-grade fibromyxosarcoma, and FUS-FLY1 is one of the examples of a fusion you can get in Ewing sarcoma. And complex cytogenetics are a number of different things, including undifferentiated pleomorphic sarcoma, myxofibrosarcoma, and others. So excellent job. All right, so when we're looking through and we're thinking, we're doing our describing, and we're thinking about how we want to sample this. As usual, we want to sample areas that appear different. We want to make sure we capture all of the different types of appearances within the tumor. And one of the things to note is that there's many types of sarcomas that can undergo high-grade transformation, and these can lead to changes under the microscopes, and they can affect how the patient will be prognosticated. So the next question is, so which high-grade change can the myxoid liposarcomas undergo? Sorry about that typo. Is it fibrosarcomatous change? Is it rhabdomyoblastic change, spindle cell change, or round cell change? Okay, so we have a spread across the board. Okay, so we'll go through each one. The answer in this case is round cell change, although I was just reading the brand new WHO, and now they actually call it a cellular change. So it's an area that appears more cellular and does have a round cell appearance. So they've changed that name a bit. But fibrosarcomatous change is something that a dermatofibrosarcoma protuberans, or DFSP, can undergo. So that's an indication of high-grade change in that lesion. Rhabdomyoblastic change is something that can happen in MPNSTs, or malignant peripheral nerve sheath tumors, which will actually change its name to a Triton tumor. And spindle cell change is something that I kind of made up, but it can be the appearance of a D-diff liposarcoma. It can look more spindle cells. So that is that question. All right. So moving right along to how we would gross it. So we would want to do our descriptions, take our measurement. We want to correlate with imaging, and we would want to think about our margins. So that brings us to our next polling questions. How many margins does this specimen have? So it is pretty straightforward. Excellent. So that's the majority of soft tissue tumors have 6 margins. So that's the superior, inferior, medial, lateral, anterior, and posterior. In cases where you have overlying skin that's taken with it, that is not a margin. So in that case, you'd have 5. In general, sarcomas of the extremities have 6 margins. So great job. And so as we're grossing and as we're taking recording all of our information, we need to be thinking, of course, about how the tumor is graded and how it's staged. So that brings us to our next question. Specimens at this site, which is the most important thing to determine on gross examination for staging? Is it the size of the tumor? Is it the involvement of adjacent tissues? Is it any functional limitations, so a clinical diagnosis? Is it the extent of necrosis in the tumor? So what do you all think? Okay, size, good job, excellent. So particularly in this question, we said at this site. So sarcomas are staged differently depending on where they are. So they're staged differently in the head and neck, in the peritoneum, in the retroperitoneum, in the extremities. So in this case, in the extremities, the main determination of staging is the size. So basically, if it's under 5 centimeters, it's stage 1. If it's 5 to 10, it's 2. If it's 10 to 15, it's 3. And if it's greater than 15 centimeters, it's a T4. So that's a pretty straightforward system. Once you get into things like intraperitoneal sarcomas, then the only thing that matters is the involvement of adjacent tissues or of other organs. And at some sites like the head and neck, both are taken into account. So you need to know the size and you need to know what other structures are invaded. So good job, everyone. All right. So we'd want to measure it appropriately, again, because it will allow us to determine the staging. And the other thing that we want to look at when we gross is the heterogeneity. So it has sort of these areas of whitish, yellowish decoloration or discoloration. So what do you think this might be? What do you think this might represent? Again, just in the chat. Necrosis, yeah, great. And so necrosis can happen for different reasons. It can happen just because of the nature of the tumor. Often in sarcomas, it's considered to be a high-grade change. In the case of this lesion, they did have pre-op radiation, so this might be related to radiation effect as well. But it's really important that in the gross examination that we estimate the percentage of necrosis, because that will be factored into in the grading of the sarcoma. So there's 3 components to grading the sarcoma, and just in the interest of time, I'll just go through them. So it is the number of mitoses per 10 high power field. It is the amount of necrosis. So the main thing for grading is you want to know if there's none, if there's less than 50%, or if there's more than 50%. So that's important to determine on gross. And and the degree of dedifferentiation, which is something that is either predetermined by the type of tumor it is, or by the appearance under the microscope. And not all sarcomas are graded, but that's something you can review in the CAP protocol, but I won't go into it now for the sake of time. So generally for grossing this, we'd want to, at least at this institution, take 2 sections per margin, as we've already discussed. And then we'd also want to sample 1 per centimeter of the tumor. And another way that these specimens are grossed at this institution is that they try within reason to put in a full face of the tumor just to give a real representative representation of what the tumor as a whole looks like, because sometimes what looks like necrosis grossly doesn't correlate microscopically, and that is an important determination of grade, so that will be important to take into account. In this case, because it was been pre-treated with radiation, it would not be graded. All right, so I think that is all we wanted to cover. Does anyone have any questions, comments, insights, thoughts?
Okay, if not, I just want to say a big thank you to Susan. That was an amazing.
Thank you for having me. Sorry we went over time, everyone. I got excited.
Amazing show.
I got excited.
Thank you all for attending, and we'll see you again for next week.
Thanks again. Bye.